Good afternoon, everyone. I'm Marlene Smedu. I'm the team leader for RPIW number 2, which is Mental Health Outpatient Services, from the time of a referral to the time the service is determined. I would prefer to stand, but I need to switch my own pages, so I will be sitting here. I hope I'm not blocking the screen for anyone. Our team has an agenda for our presentation, which is in front of you and not focused. Our team picture identifies we had 8 people on our team. We actually were missing one person who we intended to have with us. One of our patients was not able to be there, but we do have a patient representative, which is our rule for moving ahead, and the team was exceptional. Our project form identifies the purpose of doing the RPIW in the mental health outpatient services with a focus on intake. Currently, the general practitioners send referrals to the mental health unit targeted specifically to a psychiatrist. The psychiatrist wait list is anywhere from 8 to 9 months. There are about 400 patients on that wait list. Intake services, the social workers and registered psychiatric nurses who work there, are able to triage getting patients to the right services in a timely fashion, other than when there is a specific reference or referral to a psychiatrist. They also receive referrals from a variety of other sources. There were a couple of defects we picked up. One was that intake workers are often not available at their desk with their phone free to pick up calls from patients. And then when they try to call the patients back, there is about a 35% rate where they aren't able to reach the patients. It's reassuring to know that our severe and very severe patients are dealt with in a timely fashion, but that's still a number of patients who are waiting a long time for services. At this time, intake workers consult with psychiatry on a weekly basis. When we started our RPIW, and we felt that there needed to be less batching. And we also wanted to acknowledge that our intake workers do other work in terms of supporting clients than just their intake, and we wanted to free up as much time for that other important work by streamlining the intake process. So our goal is efficient and accurate handling of referral service determination, lead time reduction, and efficient use of all and appropriate outpatient clinic services. We had significant PQA information. We knew the average number of referrals a month was around about 261. We knew that the bulk of the referrals came from GPs. Those were typically faxed referrals, although you can see there were a variety of other sources of referral, including self-referral. We had information about the number of times that clients left phone messages that went to reception when they were trying to reach an intake worker. We also had some good information about the utilization of tools to support a better streamlined process for getting phone messages, and we were confident that what we're proposing will also bring that number down in the future. And we had information about the number of times that intake workers were not able to contact patients when, after probably playing telephone tag, days or sometimes even weeks had passed. We established our target progress report and results sheet, and Tim is going to talk about our accomplishments, so he'll go through the categories at that time. And of course, the TAC time, the client demand, based on, although there's a wide variety in the number of calls in a day, based on sort of a component time, what the clinic needed to be able to handle and what each of the intake workers, at the time we were doing these time observations, there were only 2 intake workers. Some of you would have been engaged with the development of the value stream map previously. Our work was actually at the very front end before the patient came for services. It was that determination of services. And so we established our own process flow, which focused specifically on the intake process with a variety of sources of referrals and the time components and the places where those referrals would go.
Good afternoon, my name is Angie, and I'm going to be talking to you about our secondary theme, the intake process improvement. Marlene and Tim observed the intake process to time the 6 components involved. Standard work in the process would be expected to decrease time and increase our productivity. Our pre-layout of our intake offices involved one main, fully functional, safe intake office, which had a daily rotation of an intake worker. All work in progress was housed here. And the other office on the bottom that has Sheila and my name there, that was shared by 2 staff, and that limited our functionality. The spaghetti map shows a typical travel involved with the intake progress to our mailbox, to our intake inbox, to our clinic shared printer, and to our intake file cabinet. The pre-Kaizen percent load shows time typically involved with a number of referral sources. Our idea summary sheet identified the problem of the files in the printer not being conveniently located. Our after improvement, the files in the future printer centrally located to improve access and decrease our travel time. Our post layout of our intake, we now have 3 fully functional, safe offices. We have 3 intake workers who are functional at full capacity. And we have a central area for our files and our new printer that is accessible to intake workers at all time. And we have our portable intake work in progress that can go from office to office.
Good afternoon. My name is Deb, and I'm going to focus on another aspect of the work that we did around screening in intake as a team and with the staff in the clinic. So what you see before you is the pre-Kaizen screening tool, which was 5 pages in length and took some time to complete. We had ideas on how this could be improved, both in terms of examining the tool itself, and we also wanted to take a look at whether we were using the skills of the intake staff optimally. Was there some work that others, health records, admin support in the clinic could be doing to free up more of intake time to be able to focus on client assessment? What you see before you now is the post-Kaizen screening tool. So through our work with staff in the clinic and his team, it was determined that health records clerks could complete, using the client information system, the demographic information on the screening and assessment tool. That would save time for intake staff. We then looked at the tool itself. What is absolutely essential in terms of the tool, in terms of being able to assess clients and make decisions about optimal service? And we looked at areas next of kin, client motivation stage of change, which is directed at addictions as opposed to mental health intake, and in the risk assessment area, which in essence is really already summarized in the assessment tool and completion of other areas. In combination, we were able to reduce through those changes 9 to 12 minutes of intake time. We then developed standard work for health records, admin support, and for intake in moving forward with the change. We developed a skill training checklist for the health records and admin support staff to ensure that people are appropriately trained. We then took a time observation. We didn't have an actual patient come through by the time we'd made the changes, so we did a mock-up. We were able to reduce cycle time by 20 minutes. Down to 22 minutes, a significant increase in productivity for intake. We've been able to reduce the travel time in the intake process that intake staff were using before. And as previously noted, our cycle time for the process has decreased by 20 minutes, which means more capacity and more productivity for intake staff and better service to clients and patients.